they might have cookies, then they're going to be more likely to reach for a cookie because it's there. So we might have them switch it to something like grapes. Something really simple, but it actually can make quite a difference. So this comes back to this idea of that conditioned response, where you can have, are any of you not familiar with Pavlov and conditioning? Okay, so the idea is basically that just the sight of something that's even not related to food over time can lead to a craving. The third piece that we address that I think is particularly helpful to address in the individual treatment that we do are some of these other psychological factors that can make it more difficult for people to make changes to their eating or to lose weight. So as I mentioned before, things like emotions, negative emotions, stress, specifically things like depression, are associated with greater rates of obesity and more difficulty with losing weight. There's also something called binge eating, which is now an eating disorder. And in our clinic, we do also treat folks with eating disorders. Binge eating is much more common in people with obesity. And it's, again, an eating disorder that's characterized primarily by having these episodes of eating a really large amount of food in a short period of time and feeling a sense of a loss of control over what you're eating. Now, if some of you are thinking, oh, I've had times like that, it's not just that. There are lots of other things, too. But what we know is that people who have difficulties with binge eating may have even more difficulties losing weight. So we want to make sure that we're addressing that in treatment as well as some of the other psychological factors that I mentioned, things like depression. So our treatments will address all of those things. The standard package that I gave you, and then what we do is we will individualize that treatment to also address some of those other factors that could be making it more difficult for the person to change their eating or weight. The other thing that I think is important to mention when we're talking about obesity or when we're talking about eating difficulties is that people with obesity are subjected to increased rates of discrimination or bias. So weight bias or weight discrimination has been reported and found in all types of different places, everyone from primary care physicians to employers. So it's not like just in certain situations. And there's research showing this, as well as when you work with individuals, they'll talk about having certain experiences where people are making assumptions just based upon their appearance. So when we work with individuals, we also want to make sure that we are addressing their experiences with bias and discrimination. And from a policy or a social perspective, it's really important to begin to correct some of those misperceptions. Okay, so that brings me back to what we're doing here at LaSalle, so bringing it full circle. We're kind of doing two things. One is with the community at large. So our clinic that I mentioned earlier is actually for members of the community. We actually don't work with students. We work with members of the community and then others, but it's primarily, I think, members of our general community. We provide low-cost sliding scale services for members of the community, and we provide both individual as well as group services. And so those individual services are really catered to that particular individual's needs. And so what we're doing is we're able, as I mentioned at the beginning, we're able to provide these services to people that I think in many other situations probably wouldn't be able to receive these services. As far as the university community, we, and by we, I mean my students and I, are doing some research to look at furthering our understanding of factors that contribute to eating and weight difficulties in college students. And I also have a student who's looking at weight-related attitudes and bias among healthcare providers that work in student health centers. So these are some of the, I'll provide these slides so you don't have to feel like you have to write these down, but these are some of the resources that I had mentioned. This is the Rudd Food Center with the University of Connecticut, and then one major organization that has a lot of information about obesity, another that has a lot of information about eating disorders, and then this is the contact information for our clinic. And that's it. I know I went through these a little bit quickly, so what questions do people have? Yes?
Can you expand on the services you provide individuals?
Yes. Most of the people that we see are coming to us for something related to weight loss. And most of them do not, most of them also have something else that they're struggling with in addition to obesity. So for example, most of the people that we're seeing have obesity and depression, or obesity and binge eating, or obesity and an anxiety disorder, or post-traumatic stress disorder, or something else that's making it even more difficult for them to lose weight. So the individual services that we provide are usually a combination of the behavioral weight loss plus other techniques to address some of those other things that they're struggling with. I don't know if that, I could give you more detail about what those look like, but I don't know if that, does that answer your question enough?
Yeah.
Okay. There are also sometimes people, we do see some folks who aren't looking to lose weight. So as I mentioned before, we do also provide treatment for individuals who have other eating disorders, but that's, I think, much less common in our clinic than addressing either binge eating disorder or obesity. Are there questions about what we do or what I talked about?
I'll try not to. Oh, go ahead. I have one word at the end, just before you go.
Yes. I don't know anybody's name, so
This one's not so much about like what we're gonna write about, but
okay, that's fine.
Is there anything that's more like reliable than the BMI? Because that's told me that I was overweight when I was like really skinny, so I know that it's unreliable.
Yeah, that's a really good question. So for children, I'll get back to adults. For children, we actually don't use BMI. We use what's called a Z-score, which is basically looking at where that child's weight falls in relation to a typical distribution of weight. BMI has been criticized mostly because it doesn't take into account things like muscle weight, and it also doesn't take into account things like the way in which your body fat is distributed. But to answer your question about whether there's a better way, sometimes people will use like a percentile score. So if you were to look at other people who were your age and gender, where do you fall in terms of that percentile? I think BMI is probably just used because it's sort of one of the more accurate ones that we have, but it definitely has its flaws. So I think other ways of looking at it are percentile, percent body fat is another big one. Another one is that I was referring to is how your body is distributed. I don't know if any of you have heard of like an apple versus a pear shape. So we know in terms of health outcomes that having an apple shape where your body fat is distributed centrally is worse. So it's associated with more like heart disease, for example, than having a pear shape. So that means that if you go to a doctor and they take a measurement of your waist, that could be another thing to look at, is if you have a waist circumference that's kind of over a certain cutoff. But yeah, that's been a big criticism of BMI, and it's kind of one of the better markers, quick markers that we have still to date. Yes?
Can you expand a little bit? What you brought up the weight loss groups.
Yep.
Can you maybe talk about like the ratio between men to women that are there, and maybe like a little bit about what goes on with those groups?
Yes. Yeah. So generally, I would say across the board, both in terms of individual and group treatment, we see mostly women. And I think that's probably the case across the board, regardless of where you're working, is that we see more women coming to treatment than for men. You could hypothesize about why that might be the case, that women are more willing to get treatment than men, for example. Rates of obesity are pretty equal between men and women, so it's not necessarily about that. But that's pretty common, is that you tend to see more women than men. In our area, we also tend to see, I think, more African American women than any other group, and that also may be a function of where we are. So that sort of answers your first question. The second question, the groups look very much like that same structure that I was showing you before. So this one. We do it somewhere, they run for between 12 to 20 weeks. It's usually anywhere from, this last one that we ran ended up just being 3 people, because I think a lot of people in the community still don't know that we exist. But anywhere from 3 to 10 people. And what we do is we spend the first, say, quarter doing what we call check-ins, where people talk about their previous week. They share the self-monitoring. They talk about what their goals were that they set the previous week, how they did with implementing new skills, and then we teach something new, and then we review it at the end. Yes?
So it sounds, I know this is going to sound messed up, but it almost sounds like an AA meeting in a sense, where it's kind of like, people coming together, working together and for a common goal. Is that my...
There are some common themes there, and I think that's the biggest common theme is the support. So one of the reasons why I think groups in general can be so effective is because they provide a lot of support, especially for people who don't have a lot of support. This is very different from AA, though, in that it's much more structured, and there are a lot of skills that we're teaching people, whereas AA is, I think, very different in that regard. And it's also run by trained professionals as opposed to AA, which has a very different model. But in terms of the group, I think it's pretty similar. And then another question that we often get is how is this similar to or different from Weight Watchers? I don't know if that's what you were going to ask, but it's different. Some of the principles are the same, but I think we have more of a focus on changing behaviors, learning skills, and then individually we do things that are a lot different from what people might encounter in Weight Watchers. Yes?
You mentioned that you guys, not a lot of people know about you guys, so how are you able to get the word out to members of the
Yeah, that's been tricky. I would say I've been here for a little over 4 years, and this clinic wasn't here before. The clinic was here, but this sub-clinic wasn't here before I was here. So what we've done is we've posted flyers, and we've tried to spread it through word of mouth just by contacting other organizations locally that, like other institutions, other universities, for example, that provide similar services. But we haven't run advertisements, because we don't have any money to do any of those things. So that's really tough. That's definitely been one of the biggest barriers. Yeah.
So first, where do you post these flyers and things like that? Is it on campus? Is it in like local stores or something?
We don't post them on campus because we mostly don't post them on campus because we don't see students or faculty and staff usually, so that's not targeting the audience. So the flyers that we've posted, our clinic is in Benilde. So if you're familiar with Benilde, there's a part of Benilde that's associated with the hospital, and there are a lot of clinics within that place that are not associated with LaSalle. So we'll post some flyers there, or just around the local community, bus stops, train stations, the grocery store.
And to keep going,
Yeah.
what was I about to say? What about like social media presence? Is it anyone ever?
No, we don't have anything like that.
Nobody ever considered it?
I don't know the answer to that question, but we don't have anything like that. Yeah. Yes.
Is there a fee for this?
Yes.
How much is that?
But it's a sliding scale. So I don't want you to quote me on the minimal amount, so I don't remember exactly what it is. But the minimum amount is somewhere less than like $20 per week. So it's usually less than a copay. And then there's also a maximum amount. So it's a sliding scale based upon someone's income.
And kind of speaking off of that, does like insurance play a role?
No.
for
Good,
some people?
yeah, good question. No, we don't accept insurance.
Okay.
Yeah, we don't go through insurance. We don't accept insurance. So it's paid out of pocket. So we try to really make it low cost so that it's affordable for people who either don't have insurance or who aren't using their insurance. Yeah.
Well, I heard a lot of talk on like the diet and like I guess the lifestyle part, but as far as pushing them to like physical aspects of it, like
Physical
what,
activity, yeah.
how do you support
Yeah.
them that way? Maybe
Yeah, that's a good question. So because we're not physicians, we always ask people to
Right. Like, do you
consult
rec-
with their physician.
Do you recommend like? Do you ever recommend like gyms or anything like that?
We don't recommend gyms, no. I mean, what we do is we focus on two main pieces. One is lifestyle activities, so things like taking the stairs or, walking the trash out to the curb, those kinds of things, trying to increase your lifestyle activity. And then we problem solve with them, knowing what their resources are, how they can engage in actual exercise. So for some people, it might be joining the gym, it might be a Y. For other people, it might be walking around the mall. It could be, we have to get creative sometimes with people. Like we've had people where their exercise is during their lunch hour, running up and down the stairs in their office. And we always ask them to consult with their physician before we work on any of that, because a lot of these people also have medical conditions. So they may have anything from heart disease to diabetes, arthritis, injuries, surgeries. There are lots of other things. So we want to make sure that they're cleared first, and then we work with them to try to come up with an exercise plan.
So like, how do people with certain conditions work around that? Oftentimes, is there like a common thing?
Yeah, it's tough. I found that swimming is one that if people can access swimming, that's one that a lot of physicians will approve. And there are some local Ys, for example, that provide assistance, a lot of financial assistance to people who don't have enough money to afford memberships. So swimming is sometimes a good one. Walking is a lot of times one that a lot of people can do. But yes, that's definitely a challenge. What else? Other questions?
I just wondered for just sort of numbers.
Yeah.
Perspective, how many people would you see over a year? And is there any sense of, there's no such thing as success or treatment, I'd say, but what kind of, do people,
Progress.
how's it working? Yeah, do they not come back? And that kind of
Yeah.
thing? What are the rates,
So as I mentioned before, it's taken a long time to get our name out there.
Right.
So I would say this year is probably the first year where we've had a relatively good number. Census. And I also want to mention that our census is limited by the number of clinicians that we have to see patients too. But right now we have maybe about 10 people, individual people, and I would say about half of them have been with us for less than a year. So it's kind of hard to say how many people are, quote, successful. Because what I've found is that some people leave because they're finished. So maybe they've learned enough, they haven't reached their, quote, ideal weight, but that's okay because that's not necessarily what we're looking for. They feel confident in their ability to implement the skills and maintain their changes. But then there are also some people who their life is so stressful and chaotic that changing their eating habits falls down on the list of priorities because they have so many other family stressors, for example, or there are people whose family members have been incarcerated, or there's a lot of community violence, and so they're coping with all these major stressors, and coming in to work on their eating changes doesn't always take priority. So it's kind of hard to tell how many people are successful. But just last year, we only had maybe like 6 clients. So I would say that talk to me in another year or two, and I think we'll have a better sense of that because we'll have more people who are using our services. Other questions?
Okay. Thanks very much. I
Okay,
think we'll put it
thank
in
you.
on a Thank you. We can be polite, respectful.